So I think the case I was going to try to make was that either something along the lines of KRD or possibly KPD, Carpomdex, may be the best option for the salvage setting. I think I do generally agree with Paul in terms of all of the wonderful options that are out there, although I also worry a little bit, frankly, because it seems that we're moving all these drugs up front, which we should, because we're still not doing the best that we can there. And I'm always reminded of the data that Bart Barloghi shows from Arkansas, where as they go from total therapy 1 to 2 to 3 to 4 and 5, the good news is that the PFS and OS from frontline therapy is improving. But then once those patients relapse, the progression-free and overall survival later continues to decline. And so my concern is that we're going to wind up with a lot of patients living longer, which is great, but for those that do relapse, we're going to be stuck a little bit in terms of what we can do. But hopefully some of these new drugs and CAR T cells and other therapies will turn that around. So briefly, just to give you the argument for Car-Len-Dex, and we've talked a lot about this combination already, but you saw the phase 1 and the phase 2 experience, which Michael Wang and also Ruben led, and that showed really nice outcomes. You've seen the Aspire data before, so I'll run through it very quickly. This was for 1 to 3 prior lines of therapy and a pretty good patient population. Response rates were quite high, including a very high complete and also even stringent complete response rate. And it used to be that we didn't even bother looking for a stringent complete response in the relapsed setting. So the fact that now you're getting such large proportions is really exciting. And the PFS data are shown here with about a 10-month improvement. And the cynics among you will say, gee, look, the Carfilzomib arm eventually looks the same as the non-Carfilzomib arm. And there's a reason for that, which I'll echo again later. But for now, I'll tell you that they stopped Carfilzomib on the Carfilzomib arm in this study at 18 months to try to make things a little bit more convenient. That's when the difference between the two arms is the greatest. And after you stop the Carfilzomib is when they start to come together. So probably had Carfilzomib been continued, the difference would have been maintained and maybe even improved upon further. And the OS data are important to remember because many of these relapsed and or refractory studies have an improvement in PFS, but not many of them have a significant OS difference. And this one so far did, although the median had not been reached for either arm. And the subgroup analysis looks exactly like you hope it would, meaning that KRD was better than RD for pretty much all of the patient groups. And we've talked a little bit about the safety profile. I think from my perspective, one of the impressive things about the study was the relative lack of added toxicity when you added Carfilzomib at these standard doses as opposed to the higher doses as we've discussed below. And that again is echoed in this slide. Some of the competition, and you've seen some of these from Paul, but of course the Eloquent study with elotuzumab, Len-Dex, the PFS curves, which he showed you a more updated version, and this is the 3-year efficacy where it does continue to show a difference, but the magnitude of the difference is smaller, so keep that in mind. And these are people on the ELO arm who continue to get ELO. They don't stop getting ELO at any time, whereas on the Carfilzomib arm with KRD, they do stop the Carfilzomib, and these are the updated curves, and the safety profile is really quite good here. You saw the data from the Tourmaline study with Ixazomib, Len-Dex, and key efficacy data were shown here and are similar to what Paul showed you. I think the point I would make here are a couple of things. First of all, the, again, magnitude of the difference between the two arms is smaller, and the length of the PFS is shorter. So certainly this is a great option. The convenience can't be beaten with an all-oral regimen, but the outcomes are not quite as good to the extent that it's fair to compare across different studies. The other thing to keep in mind here is that if you look at the FDA briefing documents for this study, in the second-line setting, there was absolutely no difference in the PFS between the Ixa-Len-Dex arm and the Len-Dex arm. And that's a little bit odd, because usually what you find is that if you give a combination earlier, it does better. If you give it in later lines of therapy, it does worse. And here that was opposite. So I would probably not consider using that for second-line therapy, but here are the data as a whole for PFS, and safety, as you heard, was quite good. Endeavor, we've talked a little bit about this study as well with KD versus bortezomib dex, and of course the results were quite positive for the carfilzomib containing arm, although again the absolute duration of PFS was shorter, although the fact that you are getting only 2 drugs may be of some benefit, and the outcomes were good even in some of the older patients with myeloma that we treat, and the safety was fairly good as well. So the preliminary conclusions in terms of KRD are really summarized here. If you look at the PFS data and compare that to the RD data, you can see some differences there. The bottom line, by the way, is a mistake. The 9.4 months should be VD, not RD. But the absolute PFS number for KRD is the best. And if you look at the hazard ratio among the RD combos, although it's only better by a hair, again, remember that carfilzomib was stopped, so it probably would be better if you had continued it. And maybe in the future, what you can do is some period of KRD and then follow that with an oral regimen like aprozomib with Len-Dex. So I think that's a really compelling argument to me, along with the safety profile. So clearly from a phase 3 perspective, this should be one of the standards of care. Now, if you're thinking about Carpom-Dex, and you heard earlier Ruben mention that he's had good success with this, we don't have a large phase 3 study, so of course it's tough to make the argument, but I pulled out these data about pomalidomide from a certain Dr. Richardson. And it does show that POM with DEX is active even in patients who have Len refractory disease, whereas we don't really have data about the opposite, which suggests the possibility that POM is more active than Len if you were ever to do a head-to-head study, which we probably will not have. And another piece of data that I think are interesting, if you look at one of the initial studies of POM-DEX from Martha Lacey at the Mayo Clinic, you can see on the right column, 62% of patients had a response to POM and low-dose DEX, whereas if you remember from the phase 3 studies of Len with high-dose DEX, the response rate was also about 60-ish%. So with POM-DEX, you're able to use less DEX, and in more heavily pretreated patients, because they're more modern, you got the same response rate, suggesting that maybe, again, POM would be better. So really the main experience with Carpom-Dex is from MD Anderson-led study that Jayton Shaw was the first author on, and this data set is from patients, all of whom were Len refractory, so it's different than the KRD data set. And you can see a very good response rate overall with good partial remissions and also some VGPRs. And there's a larger phase 2 study which will be reported out very soon as well. And the long-term outcomes here were good even in the high-risk cytogenetic patients, although the numbers are small. So I think that for me, I usually look to use either KRD or KPD as a salvage therapy, especially in the early line setting. If I had to pick one option that looks good. I think you saw the data that Paul showed about Dara-Len-Dex. At least at 1 year on that study, the progression-free survival looked better than it did on the KRD study. But that's not a randomized trial. But I think there's a fair chance that perhaps Dara with Lendex may show similar outcomes, or it'll be close enough that they probably will be fairly equivalent, and that'll be great news for everybody. So again, the summary for me would be that Carpomdex, just because of our experience with that, is our de facto salvage therapy for second line, especially since most patients now are on Len maintenance and they progress. And most of the studies that you saw with Len-based combinations were in people who were not Len refractory. So I think if you've got a patient who's progressing on Len as a maintenance, Carpomdex is probably one of the best options for them.